Dear friends, let's learn fabrication of intermediate and final surgical splint for orthognathic surgery. After articulations, the models are separated from the articulator for better handling. We have to draw 3 horizontal and 9 vertical lines. The first horizontal line is drawn in black at 20 millimeters from base of the model holder. It's also called as cutting line as the models are separated at this plane. Then 2 red horizontal lines are drawn, one 5 millimeter above the black cutting line and one 5 millimeter below the black line. Thus, the distance between the 2 red lines is 10 millimeters. The first vertical reference line is run in the midline, that is between the incisors, and 2 more vertical lines are drawn on the right and left of the midline at 20 millimeters apart from each other. Usually these lines fall in the region of the canine and the molars. On the posterior surface of the cast, 2 lines are drawn on the lateral and the medial aspect of the alveolar process, both on the right and left side of the dental arch. Thus we have 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 vertical reference lines and 3 horizontal reference lines. To split the cast, first a circumferential cut is given by a large carbide disc at the level of the black horizontal reference line. Then the central portion of the cast is separated by using handheld shock. The maxillary cast is manipulated as per the plan discussed and agreed upon by the orthodontist and the oral surgeon. Forward, backward movements, pitch, yaw, roll, all these rotational movements are accomplished as per the plan. Thus, these reference planes help in achieving the planned positioning of the maxilla. For better communication with the surgeon, all the changes, including the rotational movements like pitch, yaw and roll, are recorded in millimeters. In this case, our plan is to advance the maxilla by 5 millimeter forward without any rotational changes or change in the vertical dimension. 2 to 3 millimeter thick, mildly soft wax tops or wedges are used to position the maxillary cast at the planned position. 5 mm advancement of the maxillary cast is done with the help of red vertical reference planes at the back and lateral aspect of the cast. The vertical dimension is checked to be 10 millimeters all around as planned. We can add or remove wax if required. The separated maxillary cast and the cast on the model holder are fixed back by glue gun or sticky wax also you can use. Then the complete unit is attached back to the articulator. As the maxilla is advanced by 5 millimeters, the occlusion changes with edge to edge bite in the anterior teeth and lateral open bite. The guiding pin no longer touch the platform below. So the guiding pin is adjusted back for anterior stop. Now we will fabricate the intermediate splint with the maxilla in advanced position and mandible as the guide. Apply cold mold seal as separating medium and Vaseline over it. Then take self-cure acrylic in dough stage and prepare the bite. To prevent damage to the cast, you have to watch carefully till the acrylic setting proceeds from elastic stage to plastic stage and remove the splint before it is set hard. Put it in water for final setting. Because of the expansion of the acrylic on setting, there will be slight misfit. Hence, we have to selectively trim the occlusal surface of the splint to make it sit on the cast completely. If the surgeon prefers, we can add hooks to the lateral surface of the splint for stabilization during surgery. Last step is to apply Vaseline again and add soft reagent reliners on the occlusal surfaces of the splint to achieve excellent intercuspation. The advantages of this bilayer splint is strength by the resin core and defined occlusal guidance by the outer soft resin layer. Because of the soft resin layer, the working cast remains undamaged for final splint fabrication. The splint is tried in the patient's mouth, individually in the maxillary and mandibular arch to check proper fit and trim off any interferences with brackets or wears or whatever. Now for the final splint making. As done with maxillary cast, the mandibular cast is cut and separated. The incisal guiding pin is adjusted to the planned vertical position. Here, as no changes in vertical height is planned, the pin is adjusted to the pre-surgical height. The articulator is inverted upside down as the mandibular clasp is placed over the maxillary one at the planned position. It is usually the position of maximum intercuspation. Unless otherwise, it's a surgery first procedure or some exceptional cases. We have to check for any hindrances and trim the models to achieve planned vertical height. Then, as done with the maxillary arch, the mandibular model is stabilized with wax wedges and fixed back to the cast holder model by glue gun or This is the final occlusion to which the mandibular and the maxillary casts are set. And now, because the setup is in maximum intercuspation, if we fabricate the splint in this position, the final splint will become very thin and may break. Hence, the articulator is opened up by adjusting the guiding pin so that at least 2 mm thick splint can be fabricated. This change in vertical height will not affect the fit as phase-board transfer and semi-adjustable articulators have been used. The final bilayer acrylic splint is fabricated in the same way as we fabricated the intermediate splint. The arrow marks can be given to designate the maxillary and the mandibular side during the surgical procedure. And for convenience, it is advised to make the intermediate and the final splints in different colors. Here, pink has been used for intermediate and clear acrylic is used for final splint. Prior to surgery, the splints are tried in patient's mouth separately for proper fit in each arch, and any interference with brackets and wears are trimmed off. At the end, it is very important to communicate and discuss with the oral surgeon about the changes that are done through model surgery. Here, we have done maxillary advancement by 5 mm without any vertical changes or any rotational changes. The mandible is set back by 6 mm on right side and on the left side. Pitch is rotation around the transverse axis. The pitch change here in the mandible show anti-clockwise rotation with reduction in the anterior height by 5 mm from 10 mm. Posterior height remains same as 10 mm on right side and increased to 12 mm from 10 mm on the left side. Yaw is rotation around the vertical axis. Here what we find is the posterior part of the cast is rotated clockwise by 3 mm and in the anterior midline the rotation is anti-clockwise by 1 mm. Roll is rotation around the anterior posterior axis. Here we have an anti-clockwise rotation with 12 mm height on the left, and on the right it is the same, that is 10 mm. Thanks for watching the video. Do subscribe my channel for more interesting clinical stuff. Thank you.